Hello and welcome. My name is Mitch Sanders. I'm chair of the Communications Committee for the Wound Healing Society. And my colleague Kyle Quinn and I kind of co-chair this great session, Fireside Chat series on latest and greatest submissions to wound repair and regeneration. And today we have a very special guest, Dr. Rob Kirsner, who's chairman of the Harvey Blank Professor, Dr. Philip Frost, Department of Dermatology and Cutaneous Surgery, Professor of Public Health Sciences, a Director of University of Miami Hospital and the Clinic's Wound Center at University of Miami Miller School of Medicine. He's also one of the chief editors of Wound Repair and Regeneration alongside Boris Hines, as well as Heather Powell. Rob, welcome. Tremendous to have you.
Thank you very much, Mitch. It's a pleasure to be here, and thank you for doing this for both the Society and the Journal.
Oh, we're delighted. So what we wanted to do was talk about the article that we're featuring today, which is a brief communication from Volume 29, Issue 6, and it's the prospective randomized controlled clinical study on the effectiveness of single-use negative pressure wound therapy systems compared to traditional negative wound pressure wound therapy in the treatment of diabetic ulcers of the lower extremities, which is a subgroup analysis of patients with DFUs and VLUs with diabetes, from a study that was actually reported in 2019, also in Wound Repair and Regeneration. So it's I think what makes sense is if we could start with kind of the original study design and the outcomes from 2019, and then we'll move to the new brief report.
Great, thanks. So as many of the listeners may know, but some may not, is that over the last number of years, there's been a movement to more convenient and easier forms of negative pressure, so at least theoretically, patient satisfaction would be improved, their quality of life would be improved. And that was the premise for the 2019 paper, to compare the traditional negative pressure systems that have been in place for 15 or 20 years that tend to be big and bulky and heavy and kind of really interfere with the patient's quality of life on a variety of levels, and compare it to this new electrical single-use negative pressure device. So it's a lighter, there's not a canister, the dressing absorbs the fluid. It's really meant for wounds that are of a certain size, not for all comers, and also wounds that have a certain level of exudate, not highly exudative wounds. So the premise of this study was to compare these two different negative pressure devices. And really, what was interesting, it was set up originally as a non-inferiority study. The hypothesis was that on a clinical perspective, the two different forms of negative pressure would be equal, but there would be a patient preference for the smaller and lighter and more convenient devices. So this was a randomized trial of 120 or 30 patients, actually I think maybe even a little bit more, 160 patients, and at multiple centers, about 15, 16 centers. And the first idea that was true was that patients did prefer the single-use negative pressure. So that was true. The lighter device improved patients' quality of life and patient satisfaction. But what was very surprising and turns out to be paradigm shifting is that the single-use device did better than traditional negative pressure for healing the wounds that were involved in this study. These lower extremity wounds, not of a certain size with a certain amount of drainage, patients who received single-use healed better, healed faster, healed to a greater extent than the traditional. And that was very, very surprising, because we expected non-inferiority, and in fact, we got superiority. And the types of analysis that are done for non-inferiority differ than superiority, so we did both types of analysis and had that finding. It was so interesting that that information led to go back into the lab, and in the lab, using animal models, with very comparative wounds and of the certain size and certain depth, they went and demonstrated that yes, the negative pressure, single-use negative pressure, had better healing in those animal models, and they were able to understand why a little bit. And primarily, both devices improve granulation tissue to the same extent, but epithelialization is improved when you use the single-use negative pressure device. The reason for that is not entirely clear, but there are some theories. The first is that when you use traditional negative pressure, you put the dressing into the wound. Well, when you use single-use negative pressure, you put the dressing on top of the wound and over the edges. So you get negative pressure both for the wound bed and the wound edge, and that may allow kind of a physical phenomenon to kind of pull the edges closer and allow for epithelialization. The second is that with traditional negative pressure, you almost always use a filler. And when you pull out the filler, you can traumatize the wound bed. With the single use, you don't have to use a filler, so you don't traumatize the wound bed and you don't pull off new epithelium. So for all of those reasons, maybe some of the mechanisms involved in better healing that was observed clinically. So that was really special, where a clinical observation was made unexpected, and then went back to the lab to confirm that it truly was the case and begin to explore the mechanism. So that was all very exciting.
So one follow-up question. So there were more in the traditional negative pressure wound therapy, there was more adverse events. You think it's due to the fillers, or you think it's due to the higher negative pressure? It's what, 125 versus 80, or? Right.
So it's hard to know for sure, but I think it's a combination. I think there are a number of things that are at play, and it's always, we love to have just one explanation, but I think that is probably multifactorial. I think if we know that, for example, stress negatively affects healing. So if you have a device that doesn't create stress for you, you're able to sleep better. It's not painful. You're not dreading dressing changes. Dressing changes are done less frequently. You let lower catecholamines, and that could be a mechanism. The fact that you have a filler damaging the wound, that could be a mechanism. The fact that the pressure is slightly different, that could be a mechanism. And of course, the idea that you're treating both the wound bed and the wound edge can also be a mechanism. So for all of these reasons, this observation was made. And the wounds that were studied were both diabetic foot ulcers and venous leg ulcers. That was the study population in the initial study of 160 patients. The follow-up study, which we just published in WRR as a brief communication, was to pull out just the patients with diabetes. So they were diabetics with classic diabetic foot ulcers, and patients with venous leg ulcers who had diabetes. So we looked only at diabetic patients. And as you may or may not know, diabetic lower extremity wounds are often, that categorization of disease is often used, for example, for hyperbaric oxygen. Hyperbaric oxygen is approved for diabetics with lower extremity wounds, whether it's a venous leg ulcer or a diabetic foot ulcer. So payers pay attention to that subgroup. And we wanted to provide some additional data for the community should they think it was in their best interest to use these products in this patient population. So we pulled that data, and once again, we found similar results. We found that in diabetics, whether they had venous leg ulcers or diabetic foot ulcers, better healing, faster healing, more complete healing, and better healing in the group that got the single-use negative pressure device. So it shows that in this this difficult population, patients with diabetes, that there's a healing benefit associated with single-use negative pressure. And of course, it was kind of a double benefit. One is it's more highly preferred, and the second is it had better healing. So it really kind of what we sometimes in cost effectiveness analysis, you think about kind of a dual win, and in similar fashion, this was a dual win because you improved clinical outcomes and patient-oriented outcomes.
So with the faster healing, obviously you reduce the chance of an infection, which lowers your chance for amputation and then lowers the mortality rate. So it's kind of a win-win all around, right?
Right. So so that wasn't directly studied in this study, the osteomyelitis and amputations. But I think everybody agrees that better and faster and more complete healing reduces the complications of diabetic foot ulcers for sure. So that could be you would hypothesize that if you had enough patients and followed them for a long enough time, you'd see those endpoints.
The other question that I had was, I think you showed, I don't know whether it was at Innovations or whether it was at one of the Wound Healing Society meetings, that there was better patient compliance with the single-use device because they were more mobile. It was just so much easier to use that they liked using the device. They could get sleep using the device, whereas the other device was just so cumbersome. Part of the issue may have been compliance. Yeah,
no question. I think that we prescribe things for patients. And with our best, the idea is that what we're prescribing is going to have a benefit. But if patients don't use what we prescribe, a classic, of course, in diabetic foot ulcers is offloading. But if patients will use the intervention you're prescribing, then you're going to have better outcomes. So there's no question that plays a role in real life. But I will tell you that as part of the analysis, we do two different types of analysis. For superiority, we do an intent to treat analysis, which is the classic analysis. For non-inferiority, we do a per protocol analysis. And what a per protocol analysis does is you look at the patients who only receive the intervention. And so you kind of, and because for non-inferiority, you don't want one product to be non-inferior because they're not used. But it turned out that in both of those analyses there was advantage to the single use. So while single use is probably going to be used more because of its patients find it to be easier and more mobile, even if you control for the use, you get better results with the single use negative pressure.
One of the interesting parts of the study that I looked at during the inclusion criteria that I saw, it wasn't just the size of the wound, but also the volume. I thought that was really smart. I don't think people pay enough attention to that.
Yeah, so when you're dealing with certain wounds like venous leg ulcers, obviously depth is pretty uniform. But when you get into diabetic foot ulcers and of course other wound types, depth becomes very important. So we looked at wound size, which was length times width, but we also looked at wound volume, length times width times depth. And once again, the single use had a advantage over the traditional negative pressure.
No, wonderful. So the obvious question is, what's next for negative pressure wound therapy? And there's a lot of these new energy-based devices coming in that have potential to take some market share away, at least from negative pressure. Although some of them, the problem is it's always very hard to compare studies in the U.S. and Europe, as well as the study design is never the same. And so it's very difficult to share. The other question that I had related to, I've seen some really good studies with, if you have really good debridement and negative pressure, the healing rates seem very, very high in 12 weeks. And is that because they also have pressure ulcers or something in there that's skewing the healing rates? Why some of these studies are getting 70% healing over 12 weeks, and this is what, 39 or 40% healing?
Yeah, so there's no doubt if you look back 15 years ago or so and look at the earliest high quality data for negative pressure, it was really in diabetics who had surgical wounds. And what I mean by that is that they underwent an amputation or they had very extensive debridement, and that's where the initial use was. And that stems from the idea that negative pressure was often used for people with acute wounds, abdominal wounds and things like that. So negative pressure works exceptionally well in a kind of freshly debrided, almost an acute wound situation. As you move from that situation to the more chronic wounds, everything slows down, whatever the intervention is, including negative pressure. So no question that if you definitely want to do the best of your ability to give optimal wound care when you combine it with negative pressure. Yes, negative pressure probably has a benefit independent, but if you can combine all the best of what we know with wound care and apply it to patients, they'll get even better results.
And going back to my first question,
Yes.
what do you think the next thing for negative pressure will be?
Yeah, so that's a great question because so I think we learned a few things. The first is that just because we assume something doesn't mean it's true. So again, these results were anti-intuitive, and that's the beauty of science and research is that you have a hypothesis and you test it. But what I think was also very nice about this the study and some of the things that we should do going forward is that oftentimes when you have a new technology, you compare it to a placebo and you show it works. In the optimal situation, in an experimental situation, it works. And then you want to show it in a real life situation that it works. So that's going from efficacy, a clinical trial, to effectiveness, real life. But when you compare two technologies to see which is going to behave better in which situation, then we're talking about comparative effectiveness. And that's really what clinicians deal with every day. You usually don't you don't say to a patient, hey, I have this new product. Would you like that or would you like a placebo? No, you say, I have this new product. Would you like this or would you like the old product? And I think that gives the doctor, the nurse, the therapist in the trenches the most information so that they can say, listen, there was just a study of patients just like you, and they tested these two technologies, and this one was better for a patient like you. For your cousin who has a different type of wound, maybe the other technology works. So for big, deep, highly exudative wounds, traditional negative pressure is going to continue to be a godsend. But for the wounds that were studied, smaller, less exudate, and who could benefit from both better healing and improved quality of life, the single use seems to be a nice thing. And perhaps these new technologies will be even better. I hope so, because I'm anticipating that the next generation of therapies will be much better than our current generation.
One question that I had is, so the single use only, the small dressing only takes like 40 grams of fluid. It doesn't take a lot of exudate. Is there any way you could start on a traditional vac and then take home the single use, so you could get through the first, I don't know, I'm guessing the first week when you're in the inflammatory phase, a lot of exudate, and then switching to a single use would allow it to be more manageable for the patient?
Exactly. So the idea is when you see a patient, you say, okay, can I use single use? And sometimes the answer is no, highly exudative, larger wounds. And each single use device is slightly different in how much fluid it can accommodate. But the idea is if it's a big wound, highly exudative, you start them on traditional, and then as the exudate goes down and the wound gets smaller, then you can transition. And oftentimes that may be when you discharge a patient from the hospital. They may be in a hospital, they may get traditional negative pressure, and then you may want to make it easy for them to continue when they go home. And if the wound's small enough and less exudative, it may be the perfect opportunity. So I think we have to find in all of our patients and all of our situations the sweet spot for which patients are going to be best for which therapy.
Well, Rob, I have to thank you. This is just a wonderful brief communication. I think, thank you for everything that you do for the society and the journal. It's just tremendous. And look forward to seeing you back on another Fireside Chat very soon.
Mitch, thanks so much for having me, and I wish everybody the best, and stay healthy, everyone. And we look forward to seeing you at the next WHS meeting. So take care, everyone.
Cheers. Bye. Take care.
Okay, I guess we did it.